The subcostal window works on almost all patients. I think it should be an important component of every exam, and you will learn that in special clinical situations, this view is extremely helpful. Where is the subcostal window located? It's located here right underneath the xiphoid, and you see that you have no lung and no ribs and no sternum to obscure your view. The only problem is that the heart is located fairly far away from the transducer, so you do need a fairly low transducer frequency to get good image quality. It's ideal for imaging immobile patients who can only lie on their back, for patients who have COPD and where the lung obscures the apical window, and for patients who have a very steep heart axis where the heart is located right here behind the sternum. You can use the subcostal window in particular in situations where the other windows only provide no or poor image quality. And as already mentioned, if the patients cannot rotate into a left lateral position, and it should be used in all patients where you assume or where you believe or where you want to exclude a pericardial effusion. The further advantage of the subcostal view is that you could image the inferior vena cava, and also for patients who have suspicious atrial septal defects and patent foramen ovale, the interatrial septum. It is also a view where we can look at the pulmonic flow and where we sometimes get an even better image quality than from a parasternal long axis or short axis view of the pulmonary artery. To achieve the subcostal views, the patient has to be lying on his back, and it's advisable to also have the patient to have his legs so that the abdomen is relaxed. Now, when you hold the transducer, I would recommend that you hold it in such a way that you only touch the transducer on its sides and not below, because that way you can get much more shallow towards the abdomen, which you often have to do. Then I would just put some more gel and move the transducer from the epigastrium up while you ask the patient to inhale. Einatmen. And in that instant, you will get a view of the heart, in this case, a four-chamber view. From the subcostal window, we can get several different views. The standard view is the so-called subcostal four-chamber view, which is very similar to the four-chamber view from the apex. The second important view is the vena cava inferior view, and the third view is the short axis view of the base of the heart and other short axis views which are located more in the mid or in the apical portions of the heart. Let's first look at the subcostal four-chamber view. For the subcostal four-chamber view, the transducer is directed towards the left shoulder, and the marker is lateral, similar to where you would have it with the classical four-chamber view. So, einatmen. So what do we see here? We see the four chambers: left ventricle, left atrium, right atrium, with the interatrial septum, and here we have the pericardium, and you can see even the fossa ovalis very nicely here. So for review purposes, this is the subcostal view, the four-chamber view, with the left ventricle, the right ventricle, the left atrium and the right atrium. The peri and the epicardium can be seen, even the fat. You can see the interatrial septum very nicely, and the intraventricular septum is pointing to the right of the screen, just as you would get it if you perform a four-chamber view and you have the transducer position in a very medial position. What is this view good for? For the assessment of right ventricular size and function, for the interatrial septum, for the pericardial effusion, and in some patients it is also possible to look at left ventricular function. Probably the biggest advantage of the subcostal window is that you're able to visualize the inferior and also the superior vena cava. This gives you many clinical information, and I'll try to show you how we can get good views to visualize these structures. What you need is, you need a view where you transect the superior and especially the inferior vena cava in such a way that we get a longitudinal view. And we can then nicely see how these vessels enter the right atrium. To visualize the vena cava inferior and to get the vena inferior cava view, you start out from the subcostal four-chamber view. And all you have to do is you have to orient your transducer towards the right shoulder and at the same time rotate. So it's this motion that you're doing. Okay, and if you do this, you get a nice view of the vena cava inferior as it enters the right atrium. What you can also appreciate is that when he breathes, you have fluctuations in the size of the inferior vena cava. This is a schematic of such a view where we have the right atrium and the inferior vena cava as it enters the right atrium. In addition, we can see the hepatic veins, and in some patients, if we get good image quality, also the superior vena cava. This is the right atrium, the vena cava inferior, and here would be the superior vena cava. What is this view good for? To assess the volume status of the vena cava inferior by looking at the size. But the size also gives you information of right atrial pressure, which you will need to assess pulmonary arterial pressure. And in many situations, hepatic flow is also important to be looked at to, for example, look at patients who have constriction or restriction. The next view that I would like to show you is a short axis view of the base of the heart, now from a subcostal approach. In general, this view is not much different than the view that you get from the parasternal window. The only difference is that now you're imaging the patient from the bottom, while from the parasternal view, you would image the patient from this side. So the views are the same, they're only from a different transducer position. But both instances, you would image the base of the heart where you transect the big vessel. From the four-chamber view, from the subcostal four-chamber view, all you would have to do is you would have to rotate the probe counterclockwise, bisschen einatmen, and then you will get a short axis view of the left ventricle. And now by tilting the transducer either towards the left, you will get more the apical portions of the left ventricle. If you move it towards the right, you will get more the basal segments of the left ventricle. And if you keep on going, you will then get to the base of the heart with the aortic valve in the center and the pulmonary artery with the bifurcation. If you want to view the pulmonary artery or the pulmonic valve from a subcostal approach, you start out with a four-chamber view, tief einatmen, and then it's important to bring the basal structures of the heart into the center of the image, and then rotate around these structures until you end up with a view which gives you the right ventricular outflow tract and the pulmonary artery with the pulmonic valve here. Ausatmen, einatmen. The difference between, now we can see it very nicely, the difference between the short axis view of the left ventricle and the pulmonic valve is that here your orientation is more towards the right versus the ventricle, which is more towards the left. So it's either looking towards the right shoulder or looking towards the left shoulder. So you have the aorta as the central structure, you have the interatrial septum, the right atrium, the right ventricle with the right ventricular outflow tract, and the pulmonary artery. This is such a view. The image quality is quite nice in many patients and sometimes better than the ones you would get from a parasternal approach. You can see the pulmonary artery very nicely, and thereby this view is very good to assess pulmonic flow. You can even detect pulmonic stenosis, and you can perform shunt calculations with the help of Doppler. Let's now turn to the next view, to a subcostal view of the left ventricle in a short axis. To get a short axis view of the left ventricle from a subcostal approach, you would first acquire a 4-chamber view. Try to see that the left ventricle is in the center of the image, and then rotate counterclockwise until you get a short axis view, which looks very similar to what you see in the parasternal views, with the left ventricle here, the right ventricle here, and the interventricular septum up here. The schematic shows you the left ventricle here and the right ventricle here. What is it good for? To look at left ventricular function, even to semi-quantitatively look at the size of the right and the left ventricle. An overview of the different subcostal views we've seen so far. The classic 4-chamber view with the right ventricle, the left ventricle, the right atrium and the left atrium. Very good to assess pericardial effusion, for example. The subcostal view where we look at the inferior and the superior vena cava as they enter the right atrium. The short axis view at the level of the left ventricle with the potential to look at systolic left ventricular function, and the view where we have the pulmonic valve and the pulmonary artery, which is optimal to look at flow properties which are located there. So in summary, what are the indications for the subcostal view? I would say you should perform a subcostal view in every patient, but in particular in those patients where you have suboptimal image quality from the other views. Also very important in patients who have bad image quality due to chronic obstructive lung disease. Very good to look at pericardial effusion, perfect to look at interatrial septal defects and PFOs. Very good also to look at the pulmonic flow and to assess problems associated with pulmonary hypertension and other diseases. So this concludes the 3 views which I believe should be a standard part of every routine exam. Now I'll show you the suprasternal views, which are important in many clinical situations, but which you don't have to perform in every patient. In some patients, at least, it's also possible to visualize the superior vena cava. I'll show you how to do this. You have to first find the inferior vena cava and try to view it longitudinally. And then you would just try to rotate a bit and look to the cranial portions of the heart, in other words, to the region down here, and find the structure that is kind of a continuation of the inferior vena cava. And you can see it nicely here. This is the vena cava superior. I will put some color in here, and you will now see very nicely how the vena cava enters the right atrium. The problem, of course, is that the distance between the transducer and the vena cava superior is fairly far, so sometimes you will have to adapt the frequency of the transducer to get a better image.